because there's a few slides to go through. My name is Jasmine. I'm one of the third years, currently placed in Bendigo this year. And yeah, get to talk to you about endocrinology. This is actually one of my favorite topics because I'm not very good at memorizing things. And for me, this is a really good one that, you know, it doesn't really rely on knowing a lot, but being able to understand things. And so that's kind of the approach I've taken to the slides today. I won't be giving you huge tables of things, and I won't be going through things in great depth, simply because with this kind of topic, if you can understand it and if you can visualize those, I guess, feedback loops and diagrams, that can be really useful in approaching the entire endocrine topic. And it becomes something that you focus on, you know, when you're studying for the VIA, and then it's also quite big in third year as well. So if you kind of understand it now, then you'll understand it into the future. Whereas if you memorize things, it's going to be something that you have to keep studying over and over again. Cool. So as I mentioned, it's kind of like a big picture type system. This is a summary I made last year, and I've got a link to it at the end. It's not the neatest, but if you can map out the entire system, then you can be pretty confident that you understand how it all works. It's all pretty clinically relevant as well, so you can tie things to signs and symptoms, which is always quite good in medicine, rather than, you know, neurology, where you can't really see or experience what's happening. Cool. So everyone likes to show a breakdown of the exam marks. Endocrinology is usually within the physiology side of things, but also can step over to clinical skills and a little bit into anatomy with like histology and stuff like that. Cool. So beginning with the basics, the nervous system versus the endocrine system. So, oh my gosh, just moving things around on my computer. So the endocrine system involves internal secretions of the body through ductless glands. So the main endocrine organs that you'll be aware of are things like the pituitary, the thyroid, parathyroid, and adrenals. But there are also endocrine components of other organs. So like the ovaries and the testes. So they're not primarily endocrine, but they have endocrine functions and respond to hormones as well. And then you also have scattered endocrine cells, such as in the GIT, which we don't really cover a lot, but become a little bit more relevant when you're talking about things like neuroendocrine tumors next year. So yeah, the nervous system and endocrine system are quite similar, but also very different. So the nervous system is compartmentalized and closed. So nerves go to nerves. They don't really interact with the rest of the body as much. Whereas the endocrine system can interact with the entire body all at once. So things like the thyroid hormone have receptors on almost every cell. So it's quite like a multifaceted system. You have electrical going to chemical signals, whereas endocrine's primarily chemical. Messengers are neurotransmitters in the nervous system, so they have a high concentration. So you're getting lots of neurotransmitters in a synapse. But the receptors have a relatively low affinity, which means that, you know, when they're binding, it's not as strong. Whereas hormones have a reduced concentration because there's the entire, I guess, blood system that's got to go through. But a higher affinity. So they bind onto the receptors a bit better and cause greater action there. So you need less hormone than you would, say, a neurotransmitter. So endocrine's always involuntary. You can't really control how much cortisol you're secreting into your blood. So there's that. The speed of transmission is obviously quite different if you have to distribute across the entire body versus just from synapse to synapse. And then the duration of action also kind of corresponds with that. Hormones are generally slowly metabolized. They're not quickly degraded or anything like that we see in the nervous system. And the target area is quite different as well. So what is a hormone? Essentially, hormones are chemical signaling molecules that are released from one site to produce an effect at another. So this can happen at different areas. So autocrine means that it's releasing the molecule and that acts upon itself. It might go across a gap junction. If it's paracrine, it targets a nearby cell. If it's endocrine, it goes through the bloodstream. Just letting you know, I think I can see the group chat up here as well. So if you have any questions at any point in time, you can feel free to chuck your hand up or send through a message and I'll address those. Yeah, cool. So the hormones are defined by their chemical properties, and that in turn determines how it's synthesized and secreted. So different hormones are produced in different ways. The storage, transport, so whether it's bound to hormones to proteins or not in the blood, its target tissue and the situation there, and then the rate of removal and degradation, and that affects things like half-life. Cool. So this is a summary of the three main types of hormones. So you have your peptides, steroids, and amines. I'm not going to go through them in detail with regard to this table. It's something you can pretty much read. And this is one of the things that, yeah, it's more memory-based than understanding-based. But knowing the types of hormones can help you understand how it acts at different cells. So steroids act within the cytoplasm and nucleus, so they have to go across the cell membrane, whereas peptides and peptide protein hormones don't. So they go act on the surface, and that sets off a chain of reactions. Interestingly, the amines don't really have like a conventional way of working across the type. So you can see that the thyroid hormones work inside the cell on the nucleus, whereas catecholamines act on the surface. So that's kind of just something you have to know based on the hormone rather than the type. But otherwise, it's pretty much related to the type of hormone. So the big thing to remember is that peptides and protein hormones are hydrophilic. So they can travel through the blood freely, whereas steroid hormones aren't. So they have to be protein bound, and they separate from the protein to diffuse across the membrane because they are lipophilic. Cool. So peptide hormones, as I mentioned, they bind on the surface. So that creates a conformational change in the receptor that it binds to, and then that in turn goes on to cytoplasmic changes. So you can have things like enzyme cascades, signal amplification, and then an extended response through there. So there are a couple of examples. Iron-linked receptors are usually more common with neurotransmitters. With hormones, we're usually looking at G-protein coupled systems. So with cyclic AMP, so catecholamines, ACTH, quite a few of the hormones act in this way, and then phospholipase C. You don't really need to know the specifics of this, but yeah, there's just those two kind of systems that they work with the receptors through. Steroid hormones don't act on the surface, they go through the membrane because they are lipids, and yeah, they get picked up with a receptor in the cytoplasm, taken into the nucleus, and tend to affect gene transcription directly. So they tend to have the intracellular cytosol receptors that you can see here. I don't know if you can see my mouse, but yeah, and it goes into the nucleus, affects chromosomal DNA, and then transcription factors regulate gene expression, so the production of proteins and things, and that's how it impacts the cell function. So we'll start, this presentation is structured based upon the different organs kind of working its way down. So we'll start with the hypothalamus. You don't really need to know a lot about the hypothalamus. It's small, but it does lots of things. So it's kind of like the mastermind behind all of the endocrine function that responds to the central nervous system. So it controls the autonomic nervous system, temperature regulation, water balance, food intake and energy balance, emotions and behavior, and then endocrine secretions from the pituitary. So it's pretty much a communication between the brain and the things that it can pick up through that, and the pituitary, which then in turn does a lot of things for the endocrine system, which we'll go through in a second. This is the second. So excuse my messy drawings. This is kind of how I visualize the system. So yeah, I'm just trying to explain like my thought processes around it, and that way, you know, you can have like a really visual picture of the endocrine system. I've tried to back it up with a bit of text after each slide that I have these pictures on for those who benefit a bit more from text-based learning. So it's pretty small. It's actually pea-sized and suspended by the pituitary stalk or infundibulum. which you can see there. It sits within the sella turcica, which is a depression in the cell of the sphenoid bone, and you'll learn a bit more about that next semester. The optic chiasm is a bit superior to it. So that's why when you have a pituitary tumour, and you might notice this in exam questions, they'll mention things like visual changes, and that's because the optic chiasm, if the pressure is kind of building in this space, it can squash the chiasm a little bit there and impact vision. So the blood supply, it's a highly vascular organ. It's part of the endocrine system, so it really relies on blood supply and then the ability to secrete hormones into the blood. So it has the superior and inferior hypophyseal artery, and there's also portal circulation to the anterior pituitary, and that's because of the way that the hypothalamus inputs into the anterior pituitary gland. The different parts of the pituitary have different origins embryologically, and that kind of corresponds a little bit with its function as well. So there's the Rathke's pouch, or however you're meant to pronounce it, which gives rise to the anterior pituitary, or the adenohypophysis. And that can be split into 3 different parts: the pars distalis, pars intermedia, pars tuberalis. They're not really too important to know the details of, but it can be separated into 3 parts basically. The posterior pituitary is a neurohypophysis, and that kind of corresponds with the fact that it has a lot more of a neurological behavior than the anterior pituitary, which is more glandular, which is what adeno means. You'll talk about adenocarcinoma and stuff, and it will make a lot more sense that adeno means gland, whereas neuro means neuro. And that comes from the forebrain. So the posterior pituitary has input from the hypothalamus in the form of these neurosynapses, and that's magnocellular. And they come from the paraventricular and supraoptic nuclei. Parvocellular is the communication between the hypothalamus and the anterior pituitary gland. We'll go into detail a little bit more with that in a second, and that's basically that portal system from the median eminence. So the hypothalamus releases hormones that affect the production of hormones in the anterior pituitary, whereas the hypothalamus sends signals and transports hormones to the posterior pituitary. So the posterior pituitary gland doesn't actually produce any hormones, it just is responsible for the release of the ones that come across from the hypothalamus. Cool, so everyone's favorite topic is histology. So this is a pretty picture of the pituitary gland on a more macro level. So we have the anterior and the posterior. As I mentioned, the anterior is glandular epithelium. It has chromatodes, which are the poorly stained whitish ones. Don't really need to know much about them. They don't do very much, so they're not that important. The basophils are the deep ones, the deeply coloured purple cells, which you can see in the picture, and the acidophils are a more pink colour, and they produce different hormones. So just kind of know which ones produce what. It's the most important bit. Whereas the posterior pituitary gland looks quite a bit different to that. So there's the glial cells, which can sheath the axons and coordinate secretion. And the herring bodies are the terminal ends of the axons, and they are responsible for the storage of ADH and oxytocin. And obviously, as a whole, it secretes ADH and oxytocin. Cool, so posterior. The magnocellular neurons from the 2 nuclei that I mentioned before, they contain granules with the hormones, and that goes to the circulations. Each neuron only makes 1 hormone. And there are no hormones produced by the posterior pituitary. So the hormones come down from the hypothalamus, and the pituitary is responsible for storage and release. So you have a bit of a summary between the 2 different hormones here, coming from different nuclei and what they affect. So oxytocin is responsible for the milk letdown. So suckling stimulates mechanoreceptors in the breast, and that goes to the hypothalamus and to the nuclei there, and that stimulates the release of oxytocin. And then that in turn goes down to the breast, stimulates more letdown, which causes more suckling, and so you have that positive feedback loop. And the same thing goes for uterine contraction. It's a positive feedback loop, which is quite different to what you see in the rest of the endocrine system. Stretch of the cervix, goes to the hypothalamus, you release oxytocin, that causes contractions, which in turn increases the stretch on the cervix, and you end up with that positive feedback loop. So the effect gradually becomes greater and greater rather than lesser with release of the hormone. ADH or vasopressin is responsible for water and osmolarity regulation. So changes in osmolarity stimulate osmoreceptors, and that causes the secretion of ADH and the thirst response in the cerebral cortex. Notably, it's also responsible for hypotension, so through baroreceptors, but this is less sensitive. So you're more likely to get changes in ADH with osmolarity than you are to get with blood pressure. So how it works is it causes H2O or water reabsorption in the collecting ducts through aquaporins. So the water kind of follows the concentration gradient from the hypotonic lumen into the hypotonic medulla. You probably know a little bit more about this from your renal revision lecture, so I'm not going to go into detail. Reduced excretion of water minimizes the fluid loss, which restores homeostasis. It also has a vasoconstrictive effect on B1 receptors in the vasculature. So you have different things that inhibit it, so reduced osmolarity, and that's picked up by the carotid bodies, and increased blood pressure, which is in the aortic bodies, ANP and ethanol. So if you're drinking a lot, you inhibit ADH, which means you're peeing a little bit more than normal. And quite similar, so the opposite on the stimulate side. You also have angiotensin, pain, stress, nausea, and vomiting. But that makes a lot more sense in the context of renal. There are a couple of issues with ADH that can cause some conditions. So diabetes insipidus is the main one. So if you have reduced ADH, which means that you're diuresing more, so peeing more. So you have polyuria and polydipsia, so you're quite thirsty. Thirsty as well because you're peeing a lot more. So the test is with desmopressin, and it's caused by two different main causes. So nephro, so in the kidneys you have dysfunctional receptors to ADH. So you're producing normal amounts of antidiuretic hormone, in fact probably higher amounts, but you're not really getting the effect that you want. Whereas there's neuro causes, so reduced production and release of ADH. There's also syndrome of inappropriate ADH secretion, which has a nice acronym, and that increases the amount of ADH. So you end up with hypervolemia, so a lot more fluid in the blood area. You end up with hyponatremia because you're not keeping the salt in. You are keeping the salt in, and yeah, there's issues there. So that kind of impacts the renal system a little bit more. So you're excreting salt to try and deal with the hypervolemia, but because you don't have the right ADH happening, yeah, it's not good. And hypotonicity. So the anterior pituitary, the basophils are the same ones that are involved in the immune system. No, they're not. So sorry, that was a few slides ago, but the histology is, it kind of refers to the color of the cells. It's not a basophil as in like an immune basophil. It's a basophil because of the staining. And the basophils in the immune system are named basophils for the same reason. But yeah, it's just because it's like that blue or purple. So no, they're different cells. Okay, so the anterior pituitary has two different types, the acidophils and basophils, as I mentioned, and that corresponds with the color of the stain. So we have the somatotrophs, lactotrophs, corticotrophs, gonadotrophs, and thiotrophs. They're pretty easy to remember. Like the prefixes make it quite like suitable. Somatotrophs, like the body. Oh, growth hormone, that makes sense. So they're affected by different releasing factors, which are summarized here. So that's from the hypothalamus, and then they secrete different hormones. It's basically summarized there, and those hormones go on to act in different areas of the body. So the parvocellular neurons from the hypothalamus dictate the secretions through the median eminence and the blood supply there to the portal system and to the anterior pituitary. So secretion is dependent on hypothalamic influences as well. So this is again a summary basically of that table in a prettier form. I'm not going to go through it in too much detail because we'll talk more about these in a second. And again, another picture to visualize it, depending on what suits you. So there are a couple of pituitary issues you can have overall. The most common one is adenomas. So that's like tumors in the pituitary. Locally, you have things like visual changes, as I mentioned, the optic chiasm and headache with that increased pressure. The buzzwords that will probably become more relevant next semester when you do neuro is bitemporal hemianopia, so you lose half of your vision, and diplopia, so double vision. You can have specific adenomas, so the growth hormone secreting pituitary adenoma, we'll go through growth hormone in a second, that presents 2 different ways depending on when it occurs. You have a prolactinoma, which is actually the most common pituitary tumor that's specific. So women present with amenorrhea, infertility, osteopenia, and galactorrhea. Men present with erectile dysfunction and loss of libido. You can also have these kind of more rare ones. So Sheehan syndrome, they might mention if someone gives birth and has a lot of bleeding. So that causes necrosis of the pituitary gland, which causes, I guess, hypopituitarianism. So you'd end up with the symptoms kind of like the opposite of what the pituitary hormones do. And then you have just normal panhypopituitarism. These are really hard words to say, but then quite rare. So usually it's due to a space occupying lesion or gland destruction, and that causes deficiency in almost all of the hormones. So if you kind of get a question where nothing is working well, everything seems to be below the normal levels, then you're probably looking at this presentation. Cool, so this is just a summary. I find these diagrams really creepy, but the revision lecture last year used them, and they're a good summary nonetheless. So this is some examples of the different causes at the bottom. They're quite a good summary and show the clinical presentation. Cool. So here's the growth hormone summary that I had from my summary last year, and I've just redrawn it here. So the growth hormone is stimulated by GHRH, which is literally growth hormone releasing hormone, and somatostatin inhibits it. So things like sleep, exercise, stress, fasting, ghrelin, and hypoglycemia increase the secretion of growth hormone, and it's decreased by glycogen fatty acids, IGF-1 and H. So I'll talk a little bit more about that in a second. It's a negative feedback system. So comparing that to oxytocin, for example, the more growth hormone you have, the less that's the difference between, sorry, go back. I'm not 100% sure the difference between Sheehan's and panhypopituitarism. I think both of them are kind of like, I think panhypopituitarism is kind of like an umbrella term for just general deficiency in the hormones. Sheehan syndrome is a very specific part of it, and I think that the key differentiating factor would be the postpartum blood loss. They're not going to present a question of Sheehan syndrome without that postpartum history. So it's negative feedback. The more growth hormone you have, the more IGF-1 you have, the less it's going to be produced or released. So growth hormone does 2 main things. It goes and acts on basically every cell because growth hormone receptors are everywhere. It increases anabolic, so your synthesis functions, and decreases catabolic function. So fat, you're getting glycerol and fatty acid, and that goes to gluconeogenesis in the liver. And IGF-1 is produced by the liver in response to growth hormone as well. IGF-1 is very important. Growth hormone doesn't do its thing without IGF-1. So you end up with protein synthesis in muscle and this action on bones. So you're going from your prechondrocytes to your chondrocytes, and that helps with increased height, calcium retention, and strength. So you're looking at your strong growth. So compared to other hormones which increase fat and things like that, the growth hormone's looking at things like muscle and bone, which are helping you grow in the beginning of life kind of thing. So, you know, getting taller, getting stronger as a child, really developing those strong areas. There are a couple of hormones that interact with growth hormone and are important to its function. So glucocorticoids favor gonadal growth over any other growth. So basically they work against growth hormone a little bit. So if you have too much glucocorticoid, you're going to decrease the impact of growth hormone. If you don't have enough, then you might see some upregulation, but I think that's fairly undocumented. Apart from that, the positive hormones, so hormones that help growth hormone do its thing, are thyroid hormone. So if you have a deficiency in thyroid hormone, you end up with things like cretinism, because it's very important to neurological development. Insulin is also quite important. So if you have reduced insulin, then you're looking at things like leprechaunism. Simultaneous to growth hormone are sex steroids. So they increase during puberty, similar to growth hormone. And estrogen helps with epiphyseal fusion. Goodness. Just a second. Checking the chat again. Cool. Next. So growth hormone action, it's strong growth, as I mentioned. So you end up with more muscle, more bone, reduced fat, increased blood glucose, and then indirect insulin-like effects on the NSK. So it's kind of all summarized in this diagram here. This is from the slides last year. Yeah, so pretty much heard that. Most of this happens first distally and then towards the trunk. So compared to things like glucocorticoids, which favor truncal growth, growth hormone acts more distally on your limbs and things. Cool. And there's more details if you, I'll upload these after the lecture, the post slides. There's lots more detail and discussion in the speaker comments. I just don't have enough time to go through everything in a lot of detail because it's quite a big system. So hypothalamic control of growth hormone, you have stimulatory and inhibitory impacts. Notably, growth hormone is pulsatile. So it's kind of like episodic throughout life. It peaks during sleep. 40% of it is bound to protein and the rest is circulating freely. So the hypothalamus goes to anterior pituitary, goes to growth hormone, as we saw in that diagram previously. And it has that really key interaction with IGF-1, both negative feedback. So stimulation, as I mentioned before in that previous diagram, this is basically just a text summary of the same thing. So throughout life, it varies a little bit. So it's very high in mid-fetal life, but it doesn't really do much because we don't really have receptors for the growth hormones. It increases for young children, so that's quite high. And then it's moderately high in young adults as well. Notably quite low in old age, unless you have those issues that can lead to acromegaly. Mentioning that, you can both have excess and deficiency in growth hormone. So excess usually through a growth hormone secreting adenoma. So before puberty, that affects your long bones because they're still developing. So you end up with gigantism, so quite tall. Whereas after puberty, your non-long bones are the only ones that can grow because their plates aren't fused. So you end up with like enlarged hands and feet. So you might have that kind of buzzword. They can't put the wedding ring on anymore. Coarse facial features, so like their chin, their jaw, and that kind of thing. You can see some, if you look at photos, it's really quite a distinct change in facial appearance and like your hands and your feet. And there's other presentations as well. So you might have like skin thickening, increased sebum, acne, that kind of thing. You can have pain in your joints, carpal tunnel syndrome because of that bone growth. You're compressing the median nerve and that kind of thing. So just keep an eye out for these extra clues that you might get in the exam. Deficiency happens mostly in children, and that causes dwarfism. And there's two main types of dwarfisms that you can see. Insulin receptor deficiency, you end up with leprechaunism, and you also see hypoglycemia and hyperinsulinemia in these conditions because the insulin receptors aren't responding. Your insulin isn't doing its function as well. So not only are you going to be shorter, you're going to have these other issues. So IGF-1 receptors, as I mentioned, IGF-1 is important. So that results in Laurin dwarfism. So you have high growth hormone, but you're shorter than in just general deficiency. So you have like a large infantile head. It's also associated with anti-aging and protective against acne. So that's, I guess, a perk, but it's not good in other ways. So you treat with IGF-1, It's not reversible, but you can kind of prevent the issues from continuing. Whereas insulin receptor deficiency and growth hormone deficiency in general, you can target with more growth hormone. So these are just some of the summaries of the presentations that you might see. As you can see, the acromegaly has that really, I guess, key presentation with the facial features. Okay, so which hormone combination would you expect to see in Lara dwarfism? If you can just type in the chat, that would be fab. And the sooner people type letters, even if it's a guess, the sooner we can move on, and then the sooner you can get back to your day. Yeah, so I've gotten quite a few different ones, so we might pop back to, so yeah, it is, oh my gosh, you're giving away all the answers. Yeah, so it is A, and that is high growth hormone and low IGF. So in Lara dwarfism, the IGF-1 receptor isn't working. So you can't actually produce the IGF that you need. And you have high growth hormone still because you're not getting as much negative feedback. But yeah, that's the combination you'd expect. Apparently you haven't covered the Lara dwarfism, so I wouldn't stress too much if it hasn't been covered. I don't know if we got examined on it either. So a 42-year-old male patient has an abnormal glucose tolerance test, hypertension, obesity, proximal muscle weakness, easy bruising, decreased libido, and erectile dysfunction. After investigation, his problem is localized to his pituitary gland, a defect in the secretion of which pituitary hormone is expected. Cool. So we'll cover this particular hormone a little bit more when we move to that organ, but it is part of the pituitary. So I have received a couple of messages from people saying B, and that is correct. Yeah, so it's to do with cortisol. That presentation is really key, and what you'd expect with sorry, why is the name escaping me? The syndrome. Literally, I don't know why my brain has blanked. Cushing syndrome, that's the one. And yeah, so that's with increased cortisol, and we'll go into detail with that a bit more later. So I was just looking at the time and then I got really stressed. The thyroid. So this is one of the big important ones to know a lot about. So basic anatomy. Anatomy isn't as important as endocrinology, as I mentioned. The important things to remember, just kind of know that it's C5 to T1. More important next semester, but just in case. It's divided into left and right lobes that are connected with the isthmus, by the isthmus in the middle. So it's prevented that you see downward goiter, and that's why you kind of do the percussion on the sternum rather than above the thyroid, because of those muscles that are on top of it and surrounding it. It previously was the floor of the primitive pharynx, so it has to descend down into the neck, and that's why you end up with the pyramidal lobe, which is just a remnant of its descent into the neck. And it has lots of vasculature. It's quite a vascular organ, again, because it's endocrine. So superior and inferior thyroid arteries, and then the superior, middle, and inferior thyroid veins. Issues that you might see with the thyroidectomy, and they might be mentioned in exam questions, in particular is the recurrent laryngeal nerve. So you end up with hoarseness in the voice, much like someone who's been speaking for 40 minutes, and that's with damage to the laryngeal nerve. They also leave the sutures to be pulled just in case there is tracheal compression and suffocation with intraoperative bleeding. So that can be an emergency. So they kind of make sure that they can release it very quickly. Cool. So histology. The thyroid is quite a pretty and simple thing to understand. The follicles are essentially the bubbles. They're surrounded by the follicular cells on the outside, which is simple cuboidal epithelium, and they're responsible for T3 and T4 secretion. The colloid, the area in the middle, looks like it's storing stuff, and that is exactly what it does. It stores thyroglobulin. The parafollicular cells are, or C cells, are involved in calcitonin production. We'll mention that briefly later, but they're kind of not important. Cool. So production of thyroid hormone. So the first step is the iodide trapping. So that is involved with the symporter. It's a symporter, so the arrow with the Na should be pointing inwards, and I'll change that for the post slides. So the Na and iodide go in. The iodide is oxidized and moves into the colloid. And that's done by pendrin, if you want to know the specific enzyme involved. So thyroglobulin is produced by the rough ER in follicular cells, and then it's moved into the colloid. So it has these tyrosine residues here, which are iodinated by the iodine that's moved into the colloid as well. So it forms these two types of complexes, monoiodide thyroglobulin or diiodide thyroglobulin. And it really makes sense. The mono and the di, 1 + 2 is 3. So you end up with T3. Di and di, 2 + 2 is 4. So yeah, it's pretty simple, pretty easy to remember. And that oxidation, that attachment, sorry, is done by thyroid peroxidase, TPO. So that's kind of a really important enzyme to have working. The T3 and T4 are then endocytosed into the follicular cells, and they're cleaved by being merged by to lysozymes to their active form. So that's when you end up with the DIT and DIT coming off the thyroglobulin, and the MIT and DIT coming off the thyroglobulin. And then it's released into plasma. They're bound to plasma proteins, which we'll talk about in a second. 1/3 of T4 ends up T3 in the periphery. So most of the T3 that acts throughout the body isn't actually T3 to begin with. It's usually T4, actually 80% of it. TSH upregulates the steps pertaining to the T3 and T4 synthesis and release. And reverse T3, not really important to know about. It only has 1% of the activity of T3. So even though it's called a partial agonist, the fact that it's preventing T3 from acting means it's mostly like it has antagonistic effects. Cool. So this is kind of like a summary of thyroid hormone action. So the things that it is upregulated and deregulated by, and it's a negative feedback system, much like around the body. You end up with increased cardiac output, increased GIT motility, increased synthesis, but even more degradation of your proteins. So that's why you end up with weight loss in hyperthyroidism, and the same for fat. So even though you increase the synthesis, you're increasing the degradation even more. So that outweighs any increase. It's responsible for central nervous system development as well. So without it, you end up with cretinism. So that's why it's important to know the thyroid status of pregnant women. And everywhere it increases your basal metabolic rate, so you end up with your increased oxygen consumption and increased heat production. The increased beta adrenergic effect is also really important to the symptoms that you might see. Cool. So TSH regulation. So TRH goes from the hypothalamus to the pituitary, which releases TSH, which goes to the thyroid gland. And those are impacted by different things. Notably, it's also impacted by the circadian rhythm. So max output is midnight and 4 a.m., irrespective of your sleep state. So it doesn't matter whether you're working night shift or if you're awake at that time, it'll still be the maximum at midnight and 4 a.m. So is it interesting? Changes in caloric intake are also very important. So if you're starving, you can't meet those metabolic demands of a higher metabolic rate. So that's why it kind of decreases in response. So transport, mostly by transport proteins. This kind of summarizes the different ones involved. I won't go into too much detail. But notably, the binding can be increased and decreased. So you end up with increased TBG in pregnancy and with other estrogen, things that increase estrogen. So that increases the binding and reduces the free hormone, which means you end up with a decreased effect. Comparatively, you can get decreased TBG, so the thyroxine binding globulin, with liver disease, major illness, and nephrotic syndrome. So that's basically things that kind of decrease protein across the body, but means that you're going to end up with increased thyroid effects. And this is mostly okay because you end up with that feedback. So for a moment, you'll have more free hormone, but then the thyroid's just going to stop secreting as much. Cool. So that's just a prettier picture of the thyroid hormone production. So there are two different types of thyroid hormone, have different bioavailabilities, different binding, and different half-lives. So T4 is, I guess, like the superior version because it has a higher half-life and it has a larger pool, but it isn't very active, which means it becomes T4 through deiodination. It becomes T3 by deiodination in the peripheries. And this is why it's usually administered as the pharmacological agent, because you can rely on the body's own systems to regulate the amount that's deiodinated, rather than putting in T3 and then potentially ending up on the other side of the spectrum, if that makes sense. And this is a summary of the overarching actions, which we've also mentioned before. And as mentioned at the very beginning, it's an amine hormone. It enters the cells through transmembrane transporters, and then it binds to nuclear receptors. I think I had a question about this either on a practice exam or the actual exam, so it's important to know. So thyroid disorders, this is the important bit. A pretty picture to summarize where the different impacts are happening and the impacts that you're going to see on the hormones. So this is some nice acronyms from the slide last year. I really don't learn via acronyms, but if you do, they are here. So this is a summary of hyperthyroidism. You can have primary and secondary. So primary, you have things like Graves' thyroiditis. Thyroiditis is really early Hashimoto's. So when you're destroying the cells in the thyroid, you have the colloid that we talked about just before. And that has lots of thyroid hormone in it, or thyroid globulin, and thyroid hormone is also stored within the thyroid. So when you're destroying these cells, they release the thyroid hormone. So you end up with hyperthyroidism to begin with. And that's before the thyroid stops producing thyroid hormone. You can also have the nodules, so the single toxic nodule, multinodular, and iodine-induced. Secondary is caused by like iodine supplements, and then a couple of rare things like struma ovari. Not important to know. Pituitary disease, again, like you have your increased TSH, and that increases the thyroid hormone. And the presentation is related to two main things, which is your BMR and your beta-adrenergic effect. And I find it really useful to separate the symptoms based upon those two things. So you can see them listed below. And then you also have things like your GIT stimulation, so diarrhea, and then other endocrine effects, so infertility and amenorrhea. Increased TSH causes goiter, so that's mostly in your secondary, but you can also have it in primary as well. Graves' disease has a very specific presentation, particularly with those eye signs. It's caused by autoimmune thyroid stimulating antibodies, so they're produced to the TSH receptors on follicular cells. So you end up with increased synthesis and secretion and thyroid hyperplasia, which causes the goiter. It's more common in women, and you end up with those eye signs, as I mentioned, as well as the thyroid acropathy, which is like the clubbing that you get in thyroid cysts. And then other causes, you have the nodules, so like lumps that work like the thyroid, so increasing the amount of thyroid that can produce the hormones, but it's also unregulated by TSH. And then the subacute thyroiditis, which begins as elevated due to the release of stores. Radio, and then hypothyroidism is the opposite. So Hashimoto's, enzyme deficiency, iodine deficiency, and then the idiopathic, the non-goiter ones are like post-surgery and stuff. So if you remove the thyroid, you end up with hypothyroidism, which is to be expected. And then it's essentially kind of the reverse of hyperthyroidism. So you end up with weight gain, cold intolerance. There's a few extra interesting ones, so like the flaky skin and balding, so you loss of your eyebrows. You also end up with renal impairment. mentation. So they're pretty important to the clinical skills and the exams there. So the etiology, as I mentioned, Hashimoto's is the same. It has autoimmune antibodies to TSH, but that causes destruction rather than production. So you end up with those antibodies in the serum. You also have drugs that can be important. So amiodarone is a really key one there. Goiter, I won't go into detail. This is more of a clinical skills thing, and I don't think we're getting very much of that at the moment. I forgot to animate these slides. So we'll just go through it. Primary hyperthyroidism. So the thyroid itself is producing more thyroid hormone. So you're going to have an increase in T4, and that's going to negative feedback. So the TSH goes, oh my gosh, there's so much hormone. We need to stop this from happening. So it drops right down. Secondary hypothyroidism. So that's when the pituitary is resulting in reduced hormone. So you end up with a reduced T4, but also a reduced TSH. Increased TSH is going to increase T4, and that's happening in secondary hyperthyroidism. And looking again at T4, you have decreased T4, so it's a hypothyroidism, but increased TSH means that it's a primary hypothyroidism. Just think about the diagram and you can't go wrong. So we might skip through the questions just in the interest of time. Recognize that I'm going too long, but these will be on the post slides. So I'd recommend going through them, quizzing yourself, writing down the answers, and keeping yourself accountable to those, or doing like online study groups or something. There's lots of questions at the end as well. Parathyroid is here. So that happens, they're just behind the thyroid. You usually have 4, but you can have like 2 to 8. They have different embryological origins. Interestingly, they switch around. So the inferior ones are initially superior and they descend differently. So that'll be an interesting thing that you learn more about next semester, sorry. One of the main causes of hypoparathyroidism is inadvertent parathyroidectomy during thyroidectomy. So removing the thyroid and accidentally taking the parathyroids with it. So it's composed mostly of those chief cells which produce PTH, and they're arranged in clusters connected by desmosomes, so those junctions. And this is a summary of the different calcium hormones. So the main one is your parathyroid hormone, and that in turn impacts the production of vitamin D. There's also calcitonin, which I mentioned before, in the parafollicular cells of the thyroid. Quite negligent. So if you remove these cells, it doesn't really impact calcium balance, but it might be involved in like the fine tuning, and it has kind of the opposite effect of vitamin D. And there's also the parathyroid hormone related peptide, and that's got a similar function. It's particularly important for tooth eruption and breast production. And this is a summary diagram of how it works. So interestingly enough, parathyroid doesn't just produce PTH. It has like pre-pro-PTH and then pro-PTH, and then the receptor endocytosis causes the PTH to do its thing. And that has like an interaction with vitamin D3, which you can see here. So the parathyroid hormone increases the amount of hydroxylase produced by the kidney, which is necessary to activate vitamin D3. So they kind of like upregulate each other, but then also negative feedback up the loop. This is a summary of vitamin D action and then the impacts of parathyroid hormone and vitamin D as well. So the importance of calcium, this is a bit of a summary of what it's important for. Interestingly enough, only 50% of the total calcium in your body is in the plasma. Most of it is in, 40% of that is protein bound, and 10% of that is complex with anions. The rest is in the bone. So that's the largest calcium reservoir. So it's no surprise that the parathyroid hormone and vitamin D3, their biggest impacts are going to be on the bones. They rely on, if there's low calcium in the plasma, we look to where it's stored, and that's in the bones. Dietary calcium is quite negligible in this entire process. So hyperparathyroidism can be caused by primary, secondary, or tertiary. Tertiary is probably the one that actually needs an explanation. That's a complication of long-standing secondary hyperparathyroidism. So that's when the cells are desensitized to parathyroid hormone. So then no matter how much parathyroid hormone you're kind of throwing at it, no matter like even if you decrease the amount of parathyroid hormone, it doesn't have an impact. So yeah, you end up with that desensitization, and that causes it's kind of like paradoxical. I'd recommend, I would explain it in detail, but I don't have much time. So yeah, recommend having a look at that, just to clarify that in the brain. And the presentation can be split up into this handy stones, bones, moans, groans, and then long QT on the ECG. And hypoparathyroidism isn't as complicated. Usually it's because you've removed the thyroid and taken away the parathyroids with it. So it does have those two key clinical signs that you can elicit. So Spastic is the facial nerve, which causes tetany. So you like tap their cheek, and then the cheek just kind of twitches for a little bit. C for Spastic, C for cheek, and then Trousseau, that's when you inflate the blood pressure cup, and it ends up with like that hand spasm. Also causes QT prolongation. Osteoporosis, I won't go into detail with, but important to know about. You also go into this a little bit more in third year. But basically, anything that impacts bone resorption will impact the density of the bone. It's pretty self-explanatory, and one of those things is hyperparathyroidism. So more parathyroid hormone, the more resorption of the bones with breakdown and the removal of calcium, which decreases the density and increases your risk of fracture. Yeah, you would have gone into this in other semesters. And then your clinical presentation, it's usually asymptomatic. It's often called a silent disease, and you don't really worry about it until you're presenting with like a neck of femur fracture, which is unfortunate. But you can also have different signs. So because the bones are kind of getting squashed because they're less dense, you can have shortening, and then these particular tests. So the wall occiput test and the rib pelvis distance, and that's just because of the compression of the vertebrae. So prevention, mostly it's like dietary, and then vitamin D supplementation might be used. Cool. So speed through adrenals, if that's okay. So the anatomy, the medial aspects of the upper poles of each kidney, it's in the retroperitoneal space, and there's those three main layers. So the fibrous outer layer is just connective tissue and stuff to protect the inside. You have your cortex, which secretes the hormones that we are all a fan of, and then the medulla, which secretes catecholamines. It's quite vascular as well, lots of small arteries. Interestingly enough, there's a plexus which allows blood from the cortex to go to the medulla. So you would notice that the cortisol is related to stress response, and so are catecholamines. So that shared blood helps them regulate each other. The medulla cells are from neural crest, and they invade the cortex, which is from mesodermal cells. So they have different origins, which is related to their function as well. I don't know if you have Michelle Lazarus still, but she's pretty keen on embryology and how it affects the function of things. And then this is your classic salt, sugar, and sex. So GFR, glomerular filtration rate. Pretty convenient in terms of remembering what each layer does. Interestingly enough, technically the fasciculata and the reticularis both do androgens and cortisol, but I'm pretty sure you're taught in this way. So just remember those. And then the medulla, mostly it produces adrenaline. So noradrenaline is more important in neurotransmission. So that's why you see more adrenaline produced by the medulla, because it's going into the bloodstream, and that's what we can see in the blood as well. So here are some pictures of the histology. Notably, they can ask you histology questions, so it's nice to have like a general idea of what the layers look like. But I heard you don't have proper exams, so that's also nice. And here's another picture as well. So steroid biosynthesis is pretty important to know a bit about. I'll highlight the important parts of it. So it's based, you end up with cholesterol, and that The intake of cholesterol is affected by ACTH, and the entry of the cholesterol is impacted by STAR, which is kind of like highlighted here. So you might hear about that. And the different layers kind of have different processes, and they all vary based upon the number of carbons. So you can see here 21C, 19C, 18C, etc. Not too important to memorize. Very low yield. Cool. So you can see the different enzymes and things. It's really important when you get to congenital adrenal hyperplasia, which we'll cover in a second. Notably, steroids are hydrophobic, so they travel with proteins, as I mentioned. They dissociate, go into the cell, and do their thing. Glucocorticoids, so you might have heard of cortisol, and that is the endogenous glucocorticoid, and it's the mediator of the stress response. 90% of this is bound to cortisol binding globulin, which makes sense, another convenient name, and it's upregulated by ACTH, so like when it's stress and cold, and when you wake up, it's at its highest as well. So the net effect is that it increases ketones, increases glucose, increases lactate, and decreases protein synthesis. And that's kind of summarized here. Cool. Feel free to leave if you have to. I'm just going to keep speeding through to try and get this done in maybe like 5 to 10 minutes. And this is just another summary of the pictures. So you have the carbohydrates, lipids, proteins, and caloric intake impacts in the metabolic pathway. You would have remembered that we give glucocorticoids as an anti-inflammatory. So an indirect impact of cortisol is to decrease inflammation. So you can have it in increased times of stress. So that's stress mentally and stress physically as well. It downregulates the entire immune system. So you can end up with those increased infections and susceptibility to repeat infection that you see with Cushing's syndrome. There's the other impacts, so bone resorption, so that's why you end up with osteoporosis, and impacts on electrolytes and things as well. So this is hypercortisolism. So you have Cushing's disease, which is the adenoma in the pituitary gland, which increases ACTH, so that's a secondary cause. And you have Cushing's syndrome, which refers to the constellation of the symptoms, which are summarized below. Another creepy diagram, which pretty much sums it up. So it's kind of like the opposite to growth hormone in terms of where you see the growth. You see increased fat and decreased protein in the muscles. And that happens centrally. So diagnosis and management. So as I mentioned, it's the highest in the morning, so that's a really good time to measure it as a comparative thing. They do morning plasma cortisol. They also do 24-hour urinary cortisol, but what you might remember covering is the dexamethasone suppression test, and that's summarized here. I'd recommend kind of thinking about how it functions with regards to the feedback loop. And then additionally, you might want to do CT and MRI. Ectopic production of cortisol usually happens with paraneoplastic syndrome, so that's cancers, usually of the lung. So you might want to do a chest x-ray of the lungs as well. Adrenal insufficiency, so that's your Addison's disease. It's most common in females than males. And you end up with kind of the opposites of Cushing's. Interestingly, ACTH causes skin changes. So if you have in primary adrenal insufficiency, you have increased ACTH. And that can bind to the melanocortin receptors in the skin. So you end up with hyperpigmentation. Whereas secondary, you have decreased ACTH. So you have that decreased binding, which causes lighter skin. So that's kind of like a key difference between secondary and primary in terms of clinical presentation. I'm not sure if that's examinable, but it's an interesting fact to differentiate between the two. So there's a few different causes of Addison's. One of the main ones is just they've been on glucocorticoids for a long period of time and now they're not. The body doesn't know how to produce them by itself, so it can't, and you end up with this insufficiency. Hyperaldosteronism. So you have Conn syndrome, which is usually caused by, it is an adrenal adenoma. So you're retaining more sodium at the expense of potassium. And you would have covered this a little bit with renal. We end up with like hypertension because you've got a lot more fluid retention. And potassium is pretty important to heart function and acid balance as well. So you end up with alkalosis, and that's associated with reduced calcium and arrhythmias as well, with the impact on the heart. So as I mentioned, the important part of knowing steroid production is with regards to congenital adrenal hyperplasia. So that's a deficiency in 21 hydroxylase, which you would notice is only important in producing aldosterone and cortisol. So you have decreased aldosterone, you have decreased cortisol, which is feedback into the brain that increases the amount of ACTH. Interestingly, the androgen pathway is unaffected by this deficiency. So all of the ACTH is upregulating the amount of androgens that are being produced. And there's also a backlog in cholesterol. So it has not only more, I guess, substrate to work with, it is also having more stimulation. So you have lots of androgens, and that causes hyperplasia. To test for this, you use the 17-hydroxyprogesterone levels, and that's elevated because you have this backlog. It can't move to the next step because there isn't the enzyme it needs. So you end up with an increase in that enzyme, and that can be measured to diagnose. So you end up with three main things: the hyperandrogenism, so you have your ambiguous genitalia, you might have earlier pubic hair if it's not picked up before then. Hypoaldosteronism, so salt wasting, you have your dehydration, that kind of thing, and that can cause a bit of a crisis there. And then hypocortisolism, so kind of like the presentation that you'd see with Addison's. And because you have that reduced growth hormone impact, you have increased growth in skeletal maturation because you don't have that inhibition that I mentioned before. So that's an interesting way that knowledge can be applied to the clinical setting. And then the pheochromocytoma. So that's caused by a chromaffin cell tumor in the medulla, increases catecholamine. So basically you have your upregulated SNS. So anxiety, panic attacks, hypertension, tremor, sweating, palpitations. Kind of similar to the thyroid presentation, and that's because it's sharing that sympathetic upregulation. But it's diagnosed differently. So you're looking at plasma adrenaline and then also urine sampling. Cool. So there are a couple of questions here which we won't cover today. Do you want me to cover the questions, or are you happy to go through it yourself? Feel free to message in the chat if you have an opinion. Send through a plus if you'd like questions and a minus if you, yep. Okay, so we'll go through these questions and then briefly touch on diabetes, and then I'll leave the ending questions for you to do. So prolonged glucocorticoid excess leads to. Send through the letters in the chat. You can message me, like I think a couple of you are messaging me privately, either accidentally or on purpose. So you can do that if you don't want people to see your answer, just so I can get the general feedback. Yeah, okay, so the most common thing sent through was C, and that is correct. So all of the questions have some like correct parts to them. So like weight gain, yes, acne, yes, but it's hypertension and that kind of thing. So C is the correct answer. And you can go through the presentation, just kind of like test yourself by just writing down as many symptoms and signs as you can remember, and then pick up on the ones that you've missed or the ones that you've got not quite right. So excess aldosterone is produced autonomously by an adenoma of the adrenal cortex. The typical findings in plasma are. So just think about, it's produced autonomously in the adrenal cortex. Yeah, so I've gotten D. Yeah, so the renin would be low and the potassium would be low, and that's because you're ending up with your salt retention. Your renin is low because it doesn't need to upregulate the RAS system. And that's simply because, you know, you end up with this hypervolemia and increased salt in the blood as well. So the renin is downregulated, like it doesn't need to do anything. And the potassium is low because you're retaining all this sodium at the expense of potassium. So that's why you have the low renin and low potassium. This is really pixelated, I didn't realize until now. So I'll just, does anyone know the answer to this question? Which part of the adrenal gland it is? So it is, I'm not trying to do stuff. Yeah, so it, does it not? Yeah, so it should be, I know it's not really clear, but the fasciculata. So it's kind of like more spread out and less densely. And then the next one, an effect of cortisol on body tissue is 2. Oh my goodness. That, I'll fix that in the post slides. But yes, it. So someone else going to explain D. In which question is that? Cortisol one. So it's not actually D. That's the wrong question answer with the ordering. It should be inducing lipogenesis. Actually, no. I'll fix this. It'll be in the post slides. I'm sorry. We'll quickly move through the pancreas if that's okay. So it's really important to insulin and glucagon balance with regards to its endocrine function. It has other functions as well. So increased blood glucose is detected by beta cells of the islet of Langerhans, and that induces insulin secretion, and that indirectly causes a decrease in blood glucose levels. So it's kind of like the hormone of the fed and full state. You can see like a summary diagram of how the different hormones work. So during states of hypoglycemia and stress, the glucagon is secreted by the alpha cells of the islet of Langerhans, and that has the opposite effects. So glycogenolysis, glucogenesis, neogenesis. So you're releasing sugar because the body needs the energy. So this can be used in IV or intramuscular treatment of hypoglycemia, particularly if like someone's overdosed in insulin, you can give them glucagon, sorry. So insulin actions, it decreases the blood glucose by binding to tyrosine kinase linked type 2 receptors. So they internalize the insulin and allow activation of that. So GLUT4 transporters are inserted into the cell membrane, and that allows for glucose uptake into the cells. So it has an anabolic effect. So adipose tissue creating more adipose, I guess, or uptaking more lipids. So you end up with lipogenesis, and you end up with more glycogenesis in muscle as well. So basically everything's taking up the energy to store it for later, rather than using it itself. So diabetes is when you have issues in this process. So the body has trouble moving glucose into cells, and that leads to increased levels of glucose in the blood and not enough into the cells. So essentially your body is starving despite having all of this energy in the form of glucose. It's kind of like, yeah, it's got all of this stuff to use, but it can't use it because the insulin isn't helping it too. So you diagnose this based on blood glucose levels. I'd recommend knowing these. And the amount is obviously regulated by those 2 hormones that I mentioned. So type 1, you don't have enough insulin due to type 4 hypersensitivity response, which impacts the beta cells of the pancreas. And because it's autoimmune, it happens quite early on. and it reduces insulin levels, which leads to an increase in blood sugar levels. Interestingly enough, this doesn't happen when you start losing function. It happens very late in the process. You lose almost 90% of your beta cells before you end up with those 3 Ps, which are the symptoms listed. So polyphagia, so you lose weight, and because you can't, your body doesn't know that it has the glucose to use, all the cells are like crying out for more food. And so you end up eating more, and you're still losing weight despite eating more because your cells just can't use it. Polyuria, so that's with glycosuria. So your increased blood sugar causes the glucose to overcome that kind of threshold. So you're trying to excrete as much as possible, and then water moves with it. And polydipsia, so that's just with your increased urination. So compared to type 2 diabetes though, the cells, like the receptors to insulin aren't affected. So that's why you can use insulin injections as treatment. This is a really key presentation. I'd recommend having a read through of diabetic ketoacidosis. Yeah, so there's like a little diagram. And the mechanisms in that previous slide are important to understanding the treatment. So you need to give IV fluids for dehydration. You administer insulin, but then with the insulin and the glucose uptake, you also have a lot of potassium that comes in with the glucose. So you need to supplement that so you don't end up with hypokalemia, which would be quite problematic to the heart. Yes, you do get you get 2 of the Ps in type 2 diabetes. So you get the polydipsia and polyuria, but you don't get the polyphagia. Okay. So yeah, there's the symptoms there. Type 2 diabetes. So the insulin, the body makes insulin, but the tissues don't respond to it well. So your pancreas is like pumping out all this insulin, and for some reason, you're unable to produce those GLUT4 transporters to take up the glucose. And there's several risks for that. And often hypoglycemia can lead to hypoglycemia. It's kind of like a vicious cycle with the pathogenesis and pathophysiology of diabetes. So the insulin means you're producing, the resistance means you're producing more insulin. And then the increased insulin acting on the cells causes all of this inflammation issues, which decreases the sensitivity even further. And yeah, so this is summarized here. So your body tries to make more insulin, but that doesn't work still. And yeah, so it's kind of ends up with this cycle of just resistance and then increased production until the production can't happen anymore because of that hypertrophy. So then you end up with the breakdown of the cells, which leads to atrophy and hyperplasia. So to begin with, you have this resistance, and that is usually because someone's having too much sugar anyway, so it just can't keep up regardless. And then the pancreas starts failing as well. So it's pretty bad because yeah, like you can't even rely on just giving them insulin. And it has different complications. So I won't go into too much detail, they're pretty self-explanatory and you should know them pretty well. And that's kind of like a summary comparison of the two. I actually have to go to a meeting. So I'm so sorry I couldn't make it through all of the questions and things. There's questions from the previous revision lecture as well as the ones throughout the presentation, which I didn't cover. But importantly, I'd recommend having a look at this slide. It has the principles of testing. So I like this diagram because it kind of summarizes what you'd expect to see with secondary and primary disease. So trophic hormone is like the pituitary to the thyroid being the target hormone. And if you can think about it in this way, it's a really good visualization of the different tests that you can do. So I'm just going through. Oh my goodness, that was not what I intended. So there's a link to the map that I mentioned before. It's a really interrelated system of feedback loops and concepts. So I'm sorry I couldn't go into all of the details and things. It's very big. But I'd recommend sitting down with all of the diagrams from the different lectures and the different presentations of the different diseases, and just really like mapping it out for you to visualize. At least that's how I learned it, and I know a few people found it quite useful with particular, like in particular for endocrinology, and that'll serve you for years to come. Does anyone have any final questions at all? Cool. I'm more than happy if you want to email me or ask any questions. My email address is there. I'm also reachable on Facebook. And I will update the slides with a couple of those changes and the answers to a couple of questions, and I'll put them up for you sometime this evening. But apart from that, good luck with your not quite exam. I'm sure you'll all smash it, and I look forward to seeing you hopefully in person someday soon.